Hello and welcome to the 2009 AN Annual Meeting. My name is Jay McBride. I'll be the moderator for the press briefing today. We'd like to welcome our press in attendance as well as those by conference call. Today we welcome Dr. Mats Ravnborg, author of the abstract titled A Multi-Center Double-Blind Randomized Placebo-Controlled Parallel Group Trial Investigating Methylprednisolone in Combination with Interferon B1A for the Treatment of Relapsing Remitting Multiple Sclerosis. After he's had a chance to speak, we'll take some questions first from the audience in attendance, followed by those on the conference call, time permitting. The abstract is embargoed until 7 p.m. Pacific, Thursday, April 30th, 2009. We'll have a few moments for questions after Dr. Ravnborg's presentation. And now I'd like to welcome Dr. Ravnborg.
Thank you very much. I'm very happy to be here. I think I'll start my presentation with some small introduction because it's necessary for you to know why we embarked on this study. So after the euphoria from being able to treat MS patients with interferon beta and glatiramer acetate subsided in the late 90s, it was clear that we had to realize that these drugs were only partially effective, with about 30% reduction in relapse rate all around. So while the pharmaceutical companies starting to invest in development of new drugs, more efficacious drugs, the neurologists globally started pondering whether it would be possible to pick certain of the well-known immunosuppressant drugs and combine it with the new drugs and thereby having some sort of synergy. So in 2001, Dr. Sevadinov and his colleagues published a paper showing that recurrent pulses of methylprednisolone with a 4 to 6 month interval for 5 years, in fact seemed to improve the outcome of relapsing MS. It was a single drug trial, but we were accustomed to using methylprednisolone for relapse treatment and felt quite secure with it. So we found it reasonable to try to combine it with interferon beta. So in the Danish MS Research Center in Copenhagen, we wrote up 2 protocols, one combining Rebif with pulsed steroids every month, a study called NORMIMS, and it was published or presented at the ECTRIMS Congress in Montreal last year. The next study was the Mecumbin study that I'm going to talk about today, which is a combination of Avonex with pulsed steroids every month perorally. The study concluded late 2008, and I'm very happy to be able to share some of the main results with you today. So if we go to the handout you've got, you can see that the scientific objective of the trial was to evaluate whether the combination of Avonex and methylprednisolone provide a more efficacious treatment for new MS patients than Avonex alone. So we designed a multi-center, it was mostly in Northern Europe, double-blind randomized group comparison of these 2 treatments. Both groups had Avonex a priori, and then they were randomized to either methylprednisolone 500 milligrams a day for 3 days, each month for the duration of the study, which was at least 3 years. And the other group had Avonex plus placebo. The patient disposition coming out of this study was that we managed to randomize 341 patients. And after having patients put on treatment, we had an intention to treat population of 167 placebo patients and 171 methylprednisolone patients. The intention to treat population is the one that is used for all calculations of the outcomes later on, which means that even though patients may stop treatment or change treatment, they still count in the group that they were allocated to. So in the end of the study, we found we had quite a lot of dropouts. Mostly, fortunately, patients who discontinued treatment but stayed in the trial. So real dropouts lost to follow-up were very few, only about 18, 19 patients in each group. So we had, in fact, a rather complete follow-up on the majority of patients. We decided upfront to use a quite daring endpoint as the primary endpoint because we decided to follow the the time to sustained disability progression sustained for 6 months. It's a very, very hard endpoint to go for because partly the EDSS, which is a scale that gives some sort of indication of the accumulation of deficits in this disease, it's not very sensitive for changes, and partly because a group of patients in very early MS doesn't change that much over 3 years. So finally, in the next slide, you can see the survival statistics, 2 curves. I don't know whether you have colors in your slides, but anyway, there isn't much.
We'll get the slides afterwards.
Okay. Anyway, the time to sustain progression, was not different. There was no statistically different difference in the 2 groups, between the 2 groups, but there was a trend. There was a trend against a benefit of methylprednisolone in addition to Avonex, but it was not statistically significant. So, having said that, we have to conclude that this study, per definition, was negative. Now, this is not a labeling study, so we can trustfully go to the other objectives to see what we can learn from them. So we had 3 secondary outcomes. The first was the mean change in the multiple sclerosis functional composite score. It's a rather new score invented here in the United States to have a more sensitive outcome measure for clinical trials. I don't know whether you're aware with it, but it's a composite of 3 main areas. It's the gait function, called the 25-foot walk timed, and the 9-hole peg test. It's a hand test, and then it's a cognitive test called the PASAT, 3 seconds. And quite exceptionally, this showed up to be statistically significant with benefit of the methylprednisolone. It was mostly driven by the 9-hole peg test, meaning that was the functional area that seemed to differ between the 2 groups. However, the other 2 groups had a trend in the right direction too, so it was not totally standing alone. When you get the slides and see the numbers, you will realize that it's very hard to know how to interpret these results. We have to trust the statistics that it's statistically significant with the benefit of the methylprednisolone, but it's not easy to know what it really means. The next secondary objective was the annualized documented relapse rate, and we had chosen a rather strict definition of the relapse rate because we needed an increase of 1 point in 2 of the functional systems behind the EDSS. There are 7 systems and for different regions of the body. And we needed 1 point in 2 systems or 2 points in 1 system. This is rather special. It's only used during the last 3-4 years in newer studies. In most of the old studies, the relapses were just defined as something a neurologist said was a relapse. So it means that when you put up strict criteria, you'll normally have a lower frequency of what you look for.